Good morning, everybody. It is a pleasure to have you with us today. As the Vice President of the Association of Brazilian Lymphangioliomyomatosis Patients, Alambra, I would like to start this interview with Dr. Daniel Dilling by thanking him for accepting our invitation to open our 10th meeting. As a LAM patient myself, I am genuinely impressed and thankful by what Dr. Dilling has been doing throughout his career to improve the well-being of LAM patients. Before detailing some of Dr. Dilling's achievements and activities, I would like to express on behalf of Alambra's Board of Directors our gratitude to the LAM Foundation and especially to its CEO, Susan Sherman, for their consistent support and care. They have spared no effort in addressing the needs and demands of Alambra and the Brazilian LAM patients. Dr. Daniel Dilling, MD, is a professor of medicine in the Division of Pulmonary and Critical Care at the Stritch School of Medicine of Loyola University, Chicago. Since 2010, he has been the director of the LAM Clinic at his hospital, where he currently oversees the care of approximately 140 patients, 140 LAM patients. He also serves as the director of Loyola's Interstitial Lung Disease Program and holds the role of medical director of their lung transplant program. In addition, he conducts clinical outcomes research in interstitial lung disease in LAM and in lung transplant and serves as the site investigator for numerous sponsored or collaborative clinical trials related to these conditions. In 2017, he generously volunteered to become the medical director of the LAM Foundation Circle of Hope, a transplant support group where he assists patients by answering their questions about transplantation and regularly participates in support group meetings for patients from all over the globe. In 2019, he joined the board of directors of the LAM Foundation. Earlier in 2023, alongside a junior colleague, Dr. Dilling published a review article in the Journal of Heart and Lung Transplantation entitled Lung Transplantation and Lymphangioliomyomatosis. This article is aimed at dispelling these misconceptions and providing clarity on the best treatment practices for LAM patients seeking or recovering from lung transplants. More recently, Dr. Dilling has assumed the role of interim director of the LAM Clinic Network, a network comprising over 70 clinics serving LAM patients around the world. One of these clinics is the LAM clinic at the Hospital das Clínicas here in São Paulo, led by Dr. Carlos Carvalho and by Dr. Bruno Baldi. Today, Dr. Dilling is here to help us gain insight into the current practices regarding the diagnosis and treatment of LAM, and we are very delighted to welcome him to the meeting. If there is anything, Dr. Dilling, anything else you believe is important for us to know about you, please feel free to do so.
Well, thank you for that kind introduction. I'm really happy to be here with you at the meeting. I am a lifelong Chicagoan, and I invite everybody to come to Chicago someday to enjoy, as I do, all of the wonderful cultural opportunities and food and sports and architecture. It has a really important architecture history, and to embrace the great city of Chicago. I wish I could be there with you. I would love to, but it was a very long trip, and I thank you for this invitation. And I also wish I could speak in Portuguese and do this interview in Portuguese, pero puedo hablar en español, pero no en portugués, así que lo siento.
Very good.
Perhaps I'll learn
So
someday.
you're very right to be so proud of Chicago. I know the city already, and I hope someday you can come to Brazil and we can have a more personal interaction. It's going to be a very great pleasure to have you here with us someday.
Let's,
Okay?
yes.
Okay. So let's proceed then to our interview, to which we gave the title Diagnosis and Treatment of Lyme, What Exists and What is Coming. Beforehand, I would like to thank Indira Luz, a Lyme patient, who is behind the scenes giving us all the technical support necessary. Thank you, Indira. Okay. So let's start talking about the diagnosis of Lyme. I have three questions about this subject. Could you provide, Dr. Dilling, a brief overview of the state of the art regarding the diagnosis of Lyme?
Okay, so as we know, LAM is a lung disease that involves having a number of cysts that are seen on a CT scan of the lungs. Sometimes it is discovered because the patient has developed shortness of breath and testing has shown those cysts. Perhaps sometimes they had a pneumothorax and the workup testing of that pneumothorax with a CT scan showed the cyst. Other times a CT scan was done for some other reason and accidentally showed us that there are cysts on the lungs. So all three of these pathways are the common ones to coming to the situation where you need to make a diagnosis for these cysts. The first and most important thing, first step for investigating the question is to have a very careful look at the CT scan itself. The CT scan of the lungs by itself will not be adequate to make a confirmed diagnosis of LAM, but the appearance of the cysts is an important element in how we approach it. Because in LAM, it is usually what we call a homogeneous, or sort of throughout all parts of the lungs, that there are cysts, that they are usually rounded, that they have a thin walled, and that pattern of distribution of the cysts is helpful in us moving towards a diagnosis of LAM, or perhaps moving towards some other kind of diagnosis of cystic lung disease. So once we have the right CT scan, we need one more thing to try and give us the confirmed diagnosis of LAM. So the things that we may look at are the following. Number one, maybe there is also a scan or an ultrasound of the kidneys, and there might be a lesion on the kidneys or a tumor on the kidneys called a a tumor on the kidneys called an angiomyolipoma or an AML. These are benign, but they can occur in about 30% of people with sporadic LAM, and even more, almost everybody if they have tuberous sclerosis LAM. The next thing to think about is, do they have an underlying diagnosis of tuberous sclerosis? Because if you do have tuberous sclerosis, or you can make a diagnosis of tuberous sclerosis, then you know with strong strong confirmation that it is a diagnosis in the lungs of LAM. Another possibility is that you have developed fluid around your lungs or in your abdomen or even some other parts of your body, fluid that we call chyle that has to be drained. And if you have a history of having chyle, this milky fluid, drained from your body, and you have the cystic lung disease on the CAT scan, then we have a confirmed diagnosis of LAM. There are two more possibilities for how you can then confirm the diagnosis if you don't have those things. Number one, there's a blood test we have. This is called a VEGF-D or VEGF-D. It stands for vascular endothelial growth factor D. This is a blood test that is a little bit difficult to organize because very few laboratories are able to do this blood test. But if you have a cystic lung disease and you have a very high level of this VEGF-D, then you can have a confirmed diagnosis of LAM even without doing any more testing or any more biopsies or anything.
Okay.
The final way, of course, that you can make a confirmed diagnosis would be to have a biopsy done of some sort. It might be done through a bronchoscope with a small biopsy called a transbronchial biopsy, or sometimes it requires a surgical biopsy, what we call a wedge biopsy through a surgery on general anesthesia, and that might be the ultimate way to make a diagnosis in somebody. But we try to avoid biopsies every time we can.
Okay. So before talking a little bit more about this VEGFD test, I would like to pose another question. How important do you think it is to have an idea of what type of LAM the patients have? Because here in Brazil, there are patients who say, I've got LAM. But when you ask this patient, what kind of LAM have you got? Have you ever undergone any test to see if you have the tuberous sclerosis kind of LAM or not? So how important it is for these patients, or for all patients, LAM patients, to know this?
Yeah, it's an interesting question to think about because on some level, it might not matter that much. If you have tuberous sclerosis LAM, but your um, uh, other manifestations of tuberous sclerosis are minor, like seizure history, or maybe sort of completely normal brain function and everything, then whether you have tuberous sclerosis LAM or whether you have sporadic LAM might not be that big of a question or that important of a question. So my approach in seeing a patient with LAM, if they do not have an established history of tuberous sclerosis, is that I'm going to look for some of the skin disease. I'm going to talk about some of the background medical history. I'm going to find out if they have a seizure history. And if I can't get any evidence of tuberous sclerosis in that way, then I probably do not investigate it any further. The only way it might matter a little bit would be in thinking about whether you're going to have children. And of course, if you have sporadic LAM and you have children, there's no concern about passing that disease along. But if you have tuberous sclerosis and have children, of course, there is the possibility of children developing tuberous sclerosis, and that would be an item for consideration in your thoughts.
Okay, thank you. We know that the VEFG test, biomarker of LAM, the one you talked about, is not easily accessible, even in developed countries as the USA. So do you know if there is any prospect of it becoming more accessible, avoiding them the need for biopsies?
Yes, this is a big problem, that there's only one laboratory in the United States, in Cincinnati, at the Children's Hospital of all places, that has an approved laboratory for measuring VEGF-D. While it's possible for many other laboratories to replicate the process, it's not a very complicated test to run. It is very difficult to get the certifications for the laboratory to run that test for clinical medicine. You can run it for research, no problem, but to run it for clinical medicine and for use in patient care, it's a big, difficult process. And as I understand it, the laboratories in the United States and many parts of the world have been sort of slow or unwilling to go through the difficulties and the process for getting this test going, for a test that is pretty rare, not very commonly used. And so I think it doesn't make economic sense, unfortunately. And so it's difficult to get the test in the United States, as well as even more so in other parts of the world. And it can get pretty expensive then to order it from another country. I'm sad about this, but I don't think there are any clear pathways to making this cheaper or more accessible. I wish for it, though.
Okay. And do you know if there are any new biomarkers being studied?
So the question of a biomarker for LAM has been a repetitive question over the last dozen years or so. We even had a big meeting in Los Angeles about 10 years ago to try and gather ideas and get momentum going to discover and study new biomarkers. And biomarker is a word that can mean a lot of different things. Sometimes a biomarker is a test, maybe a blood test or maybe some other kind of test to try and identify the diagnosis of LAM. But a biomarker also might be a test that can be useful in monitoring the disease. A biomarker might be a test that could be useful in monitoring the response to a therapy, or it can even be used in research in making it the outcome that's being measured as a new drug is being investigated or a new therapy is being investigated to be able to measure the outcome. You can actually think of the breathing test, and the FEV1 is really a type of biomarker. We use it that way already as a way of tracking. So we need more biomarkers, and there have been many discussions about this and some preliminary investigations, some of them involving radiology, some of them involving blood tests, but none have been, let's say, studied to the point that they have become accepted. We're hoping for something to change, and we're hoping for new ideas to come forward, but we're not at that point yet.
Regarding the treatment of LAM, recurring question has been about the exact time to initiate sirolimus use. The cutoff point used has been, as you said, FEV1, equal or less than 70%. The question is, isn't this cutoff point too high to be generalized for all patients, considering that overweight patients and those with short stature have reduced lung function, and that menopausal patients have a lower risk of progressing to severe disease?
Yeah, so when we're thinking about the trigger for starting sirolimus therapy in somebody, we definitely use FEV1 and spirometry and diffusion capacity, or DLCO, as well. And it's true that there can be other factors that can influence that number. And in the clinic with the doctor and the patient, we really have to think about whether those other factors are blurring the information or influencing the decision. So I'm not too worried about short stature, because the percent predicteds for the FEV1, that should take into account the short stature. Your height is factored in the percent predicted, but obesity can make the FEV1 go down and the percent predicted go down. The a pleural effusion can also make the number go down. If you recently had a virus or an infection or a pneumonia or something, that can make the number go down. Even heart failure can make the number go down. So your doctor should take those possibilities into account as they're thinking about whether or not to start the medicine. And the decision about 70% for the FEV1 really comes from the big trial called the MILES trial, done about 12 years ago, that showed us that for patients with a moderate or severe low FEV1, that use of sirolimus was very successful at stabilizing and even sometimes improving a little bit the FEV1 in a year, and even further on in patients with LAM. So we use the number 70% because the MILES trial gave us that group of people, but we do wonder if maybe patients even with a higher FEV1 might benefit from use of sirolimus as well. So we're waiting to hear the results, but there's actually a big trial called the MILD trial that just finished recruitment of 60 plus patients from the United States and some other areas to look at whether a low dose sirolimus in patients with even higher numbers than 70%, whether they also might get a benefit from starting sirolimus. And perhaps we'll know the answer in about 2 years, because it's a 2-year-long trial and the last patients just began. So in about 2 years or 2.5 years, we might know more information. We might be starting the medicine even earlier than 70%. But yes, you do have to have a careful consideration for other factors that might decrease that number. But anyone under 70%, if you really believe it, I think with a few exceptions, probably should be starting therapy with sirolimus.
Is there any indication, Dr. Dilling, that to start sirolimus in patients with recurrent pneumothorax, regardless of lung function, and even in the absence of extrapulmonary manifestations, is there any indication that this is going to be helpful?
Yes, this is a super interesting question, and one that didn't have much of an answer until recently. For background, we usually don't use sirolimus as a treatment for pneumothorax. We didn't historically say that sirolimus would help reduce your chances of a pneumothorax. We didn't know it. We would use sirolimus if you either had declining lung function, like the 70% we talked about, or development of chylous effusions, or sometimes for the angiomyolipoma. But now we know something more. There was 2 studies that came out of China in 2022, and there was another one recently presented at the American Thoracic Society just this past spring in 2023 from Cincinnati, showing us that in patients who were on sirolimus, there's a big reduction in the chances of having pneumothorax, or recurrent pneumothorax. So the next thing we must all think about is, should we be starting sirolimus for all of those patients who've had a pneumothorax, or especially if they've had recurrent pneumothorax? And I don't think there is a consensus answer to that question yet, but I think it's coming, and I feel like we're going to be using sirolimus in that situation. So not for everybody before they have a pneumothorax, and maybe not for everybody who had one pneumothorax, but maybe once you've had recurrent pneumothorax, it would be a good option to start. It would be something to discuss very carefully with your doctor, but that may be something for us to think about in the future as well.
It is known that one of the aims of sirolimus is to target the mTOR protein, which normally increases due to the elevated levels of insulin in the blood. So, since overweight and or obesity leads to a high insulin level in the blood, do you think that it could be a factor that hinders the effect of sirolimus for patients, that obesity and overweight could be a factor that hinders this development of sirolimus? Because there are some patients that with whom to whom the sirolimus is not effective enough.
Yeah, it's a very, very complex situation that you're describing. The intracellular processes that show us that mTOR is increased, and the mTOR inhibitors can be targeted by sirolimus to try and inhibit cell growth and to slow down the LAM. Those processes are more complex than that. In fact, we've learned a lot, even in the last 10 years, about many other growth factors, many other inhibitors, many other things that might be targets for treatment, all of which interact in the cell. So it's pretty complex, and some of them actually have to do even with glucose metabolism. So even to add more of a concept to your question, so does obesity and or diabetes or glucose metabolism affect the ability for sirolimus to do its good work? And all I can say is maybe. There might be many different reasons why sirolimus is not effective in a particular person. There are a lot of other factors in the milieu of the lamb cell that are influencing both the mTOR as well as these other um, um, cellular processes. So it's all I can say is it's really complex, and maybe, but I don't think that we have a clear answer.
Let's talk a little bit about hormone blocking treatments for women with LAM. What is your experience with this therapy?
Yeah. So we go back in time before I was a doctor in the 1980s, and we knew that this was a disease that affected women almost exclusively, that there was hormone influence because of the way it could become worse during pregnancies. We knew that there were some hormone. We later learned that there were hormone receptors for estrogen and progesterone on the cells. There were there was a period of time in the 1980s when uh, oophorectomy was recommended and later analyzed and found to not really be any significant influence on the disease. Later, progesterone was used as a treatment to try and suppress the estrogen and all these hormonal influences, and that was a common practice into the 90s. Later reviewed and found probably not to be effective, and we stopped doing that. But there remains this big question: are these hormonal influences important enough to perhaps give us treatment options? There was a big study. There was a big study planned back about 10 years ago to look at letrozole, which is uh, a, a drug that can shut down estrogen production in the ovaries, and that study was completed, but there weren't enough patients in it to give conclusive answers, except to say it's safe. But we never really learned if it was an effective therapy. But people continue to question that, and then other ideas for Lupron or something called GnRH inhibitors is also something that has been described as a possible future treatment option. We need more study. We don't have any information right now to say that any hormone therapies are effective or recommended.
Let's talk a little bit about pregnancy. How harmful can pregnancy be for LAN patients, and mainly to those LAN patients who are using sirolimus?
Yeah. So this is a really tough one. This is a really tough situation because many patients with LAM are young women, perhaps young women who are just starting to have families or haven't had children yet. And so this is a complicated discussion, and one that has to be very carefully taken with the patients and their families. Some patients I've seen, some patients that during a pregnancy can have some very difficult um, complications. Pneumothoraces can become more numerous or difficult to manage. Um, Oxygen situation can become more difficult, and these complications can have effects on the mother's health as well as the baby's health. And so that makes us concerned about pregnancy in someone with LAM. At the same time, though, the need to have children is a powerful one and an important one. And I have also had patients who have chosen to have children, even though they, sort of understand the potential risks. And I've seen them go through more than once. I've seen patients go through pregnancy without any difficulties at all. I see them more often. I try to anticipate any questions, and they have a special high-risk obstetrician seeing them to try and monitor the fetal health through the whole pregnancy. And I've seen some things go very smoothly too. So it can go both ways, but the one thing that's very important is that the patient makes a decision with with a good conversation, with information, and not without it being very carefully described. The question about sirolimus is a different one because sirolimus is uh, not officially considered a safe medicine for fetal health. Um, and so, with that said, there are potential concerns about fetal development in if the mother is taking sirolimus. At the same time, there would be concerns about fetal health if the mother's disease gets worse. So you're trying to balance the benefit of treating the mother with the sirolimus and the potential risk of the drug to the fetal health itself. And I've heard people. I've not had a patient stay on sirolimus through a whole pregnancy. I've had my patients go off of it for the pregnancy, but I've talked to other lamb doctors who've seen their patients through a whole pregnancy with sirolimus without any difficulties and without any problems with their children later, without any toxicity. So it is unclear whether sirolimus is safe to be taken during pregnancy. And so all I can say is that this would have to be a very careful conversation between the patient and their physician and under the supervision of a specialist high-risk obstetrician if they do go through it.
In a presentation at the fourth virtual LAM Action meeting, Dr. Debbie Clements from the University of Nottingham briefly discussed her research founded by the LAM Foundation on an existing medication used to treat another condition, which may be used in conjunction with sirolimus or separately from sirolimus in LAM treatment. What do you know about this research, Dr. Dilling? And do you know if there are other studies on drug repurposing other than this conducted by Dr. Clements?
Yeah, the idea of finding drugs that already exist and that already have gone through some of the early phase studies about safety is super attractive, not just for them, for all kinds of diseases. If you can accelerate the process of getting to an effective therapy if the drug already had some pre-existing use and went through all the testing already. So I didn't know exactly the lecture that you're talking about, so I went and listened to it recently. And so Debbie works with uh, Simon Johnson in the Nottingham Lamb Clinic and Research Facility. And I know that a lot of their work has had to do with looking at lung remodeling and extracellular matrix deposition, and two kinds of processes called the MMP and the capsaicin K inhibitors are things that they've thought about in their work. So I don't know. She was not able to disclose information about
Yes.
what the target was or what the drug was because I think they're so early in their investigations right now. And by the way, she was very clear in saying that it's not anything being used in patients right now or close to being used in patients right now. But I would guess that given the record of research that they have, that it probably is something in those. And so there are some drugs that have been utilized in the past for other diseases in MMP and in capsaicin K, and perhaps it's one of those, but I don't know for sure. There is another drug called sodium, what is it? Sodium chromoglucate that Dr. Johnson, I think, is introducing into clinical trials soon.
Good news. Anyway, so a general recommendation for managing pneumothorax in lamb patient is to perform pleurodesis as soon as the first episode occurs to prevent future ones. However, it has been observed that some doctors prefer to wait for nectar regression of pneumothorax or opt for closed drainage. What is your personal idea, your personal experience, in fact, on this matter?
I've observed the same thing in our country with many doctors who choose not to do a pleurodesis after the first pneumothorax. And the reason for this is actually quite sensible. The long-standing teaching and the long-standing approach to a pneumothorax in a person is you're allowed to have one pneumothorax, but you don't get a pleurodesis on the first one. If you start to have recurrent pneumothorax, then a pleurodesis is a good idea. The, the, the difference here is that if you know the patient has cystic lung disease like LAM, then you know that they're at a very high likelihood of having the recurrent pneumothorax. So the recommendations about pleurodesis have been modified just in the past 10 years or so to say that still a person should have a pleurodesis only if they have a recurrent pneumothorax, with the exception of people with cystic lung disease or LAM. Because the high risk of having it happen again, it's recommended that the pleurodesis be done at the first pneumothorax, at the time of the first pneumothorax. But it's also important, one more piece here, is that it's recommended that it be what's called a mechanical pleurodesis. That's instead of a talc pleurodesis. Talc is like a
Yes, we know.
powdery material that can be put into the chest to make the lungs stick to the chest wall, but it can become very sticky. And if someday that woman needs a lung transplant, it becomes very difficult to remove the lungs and put the new ones in. So for someone with LAM, just knowing that it might be needed in the future to have a lung transplant, it's recommended to have a mechanical pleurodesis, which should be done by a surgeon in an operating room through a procedure called VATS. And that VATS, mechanical pleurodesis, is the first recommendation at the first pneumothorax for a woman with LAM.
Okay, thank you. What can you, Dr. Dilling, expect in terms of future development in LAM treatment? Do you think there is anything related to CAR T cell therapies coming?
So the first thing to say is we've learned so much through the research sponsored by the LAM Foundation and many governments and many other foundations. We've learned so much about the cell growth and the cellular processes of the LAM cell and the way the LAM cell interacts with other cells around it in the tissue. And so as opposed to 10 or 12 years ago, where we had very few ideas of targets for drugs, we have many more areas that can be targeted. They can be things about mTOR, but they can also be things about lung remodeling. It can be things about how cells move, called metastasis. It can be things about how cells survive. It can be something called autophagy. It can be apoptosis, all kinds of different ways in which the LAM cells grow and stay alive that have potential targets. So I think we're going to have many new ideas in the future about drugs that should and will be tested. Second question, or second part of your question, is specifically about CAR T cell therapy. And I'm actually part of a research group that is investigating the way T cells and what we call immunotherapies might be useful in treating LAM. I work with some folks that work in the cancer arena as well as in other immunology diseases, where different drugs that can be used to enhance the T cells might be something we might think about using to help a person's own T cells fight better against the abnormal LAM cell, or whether we might be able to take the person's T cells through a blood sample and change them in certain ways. And that can be the CAR T cell therapy, or it can be other modifications of the T cell, and to take the person's own T cells, modify them, and then expand them so that we can give them back in multiple copies to be able to have them aimed directly at a LAM cell and try to target the disease cell itself. And it's a very attractive idea. CAR T cells and other T cell therapies are being used in melanoma and in other kinds of cancer right now. But we want to make sure that if we're going to do this, that we want to think about it in a way that's going to be not only effective, but very importantly, that it's safe. We wouldn't want to take somebody who has a mild disease and cause big problems with side effects of a CAR T cell therapy if that were to happen. So we're still very early in our investigations of this. We're using this idea in a mouse model right now, and we're hoping that as the studies go on, that we will someday think about which patients would be the best candidates and how to, as safely as possible, try that therapy. But we're some years off.
Okay.
It's not ready yet.
What good news on lung transplant can you share with us? Has lifespan of transplanted patients increased lately, or is there any hope it's going to increase? Also, are there new techniques being used or to wait for? Are there any special campaigns designed to increase the number of organ donors?
Mm-hmm. So yeah, my other hat that I wear some days is lung transplant director,
Yes.
pulmonologist, and so I take care of a lot of people with many different diseases who go on to have lung transplants as a life-saving therapy. I always am careful to tell people that a lung transplant is not a cure, it's a trade, because after a lung transplant, you have to take some complex medicines that are anti-rejection medicines that lower your immune system and can make you have different kinds of complications. And so it's always a balance of that. So nobody should have a lung transplant until they unfortunately have gotten to some of the advanced stages of their lung disease, including LAM. So with that said, we have some very good news. Over the past few years, we've done some studies to investigate the outcomes of patients with LAM who have a lung transplant compared to other diseases. And if you look at all diseases who have lung transplants, median survival, or time till 50% of people have passed away, is only about 5.5 years. Of course, there are many people that live much longer than that, but 50% median survival of 5.5 years. But in LAM, it's much better than that. It's something like 12 or 13 years median survival, with some people living much longer than that. And so I often tell people, of all the diseases that you can have and need a lung transplant, if it's LAM, your odds of having a very good and long survival are the best. And yes, we are constantly making small changes to the way we care for patients after transplant, or the way we monitor them, or even sometimes the surgical procedures. And things have gotten incrementally, although slowly, better over the last decade or two with the results of lung transplant recovery. With regards to trying to increase the number of donors, because that is a big problem. We don't have enough donors.
Yes.
And donors, it's not, you can't be a living donor and give a donation to your brother or sister or child. You have to be brain dead yourself or dying yourself to become a donor. And so there, it can't be anyone who has died. They have to be still um, uh, in the final stages of death in a hospital, probably on a breathing machine and everything like that. So to find these patients and to increase the number of donors has been a big challenge, but we need to attack this challenge because we don't have enough donors. So one big thing that's happened over the last 10 or 15 years has been really important, and you'll be glad to know that a Brazilian has been very central to this discovery. A man named Marcelo Saipel at the University of Toronto in Canada is part of the surgical team there, and they have developed technology where lungs from a potential donor can be removed and put inside a machine that keeps them alive, breathes air into them, and pumps a blood substitute into them, where you can look at lungs that you are going to discard, and you look at them in this machine, and you can see more clearly than you could before that they are sometimes good lungs. And then you can take them for transplant. And these are lungs that were going to be discarded before because everybody thought they were bad when they were having difficulty inside the donor.
Very good.
So the Brazilians are saving the day and bringing us not only more donors, but Dr. Saipel and his team also is showing us ways that you can even treat those lungs while they're still in this machine to make them even better for the transplant recipient.
Very good.
Yeah.
Impressive. We have finished now our interview, and I would like to thank you, Dr. Dilling, for sparing such a long time with us. Contributions like yours are priceless, and since our interview is going to be posted on Alhambra's YouTube channel, I believe people from all over the world will be able to profit from this very valuable piece of all the valuable pieces of information you have shared with us today. So thank you again.
Thank you.